Hey y'all, Dr. Maynard here, one of the EMS medical directors with Best EMS, and I am excited today to talk to you about pre-hospital ultrasound. This is going to be the first introduction to ultrasound, and you're watching this video because your agency has purchased an ultrasound, most likely the Butterfly IQ device. And so we're going to talk about how to use that device and talk about how to get some practice. So what's on the agenda? We're going to talk about how ultrasound works, and we're going to talk about common terms, some anatomy, some device settings. And then coming soon, we're going to talk about how to actually use the device, and that's going to require some hands-on practice. So let's start with the basics. What is ultrasound? The physics of ultrasound. Well, ultrasound is basically a diagnostic imaging technique that uses sound rather than radiation in order to produce an image on a screen. Whereas things like CT scan and X-rays use radiation, we're going to use a sound wave. So what is sound? Well, basically sound is a mechanical wave. So if I can get this image to appear here, it's a longitudinal wave. So basically we have a vibration, which is simulated by this red plunger, and it's going to squeeze these particles and send them moving to the right side. You can see that these repetitive vibrations produce these waves, and basically from peak to peak, we get what's called the wavelength, and this has to do with frequency of the wave. And we'll talk about more about that later. What you'll notice is that these particles don't actually move very much. If you focus in on one of these red dots, they don't actually move very much, but the wave actually moves the entire distance of the screen. All right, so coming on back to the presentation here. So how does ultrasound work? Well, basically it uses echolocation. And if you're familiar with how bats can locate a flying insect, they basically send out a signal, it bounces off that insect, and then comes returning to the bat. It can sense the location and actually even locate it while both objects are flying, which is pretty amazing if you think about it. Another analogy is a fish finder. So most of us have experienced how this works. So you send a signal down as indicated by these blue arrows in the diagram, and basically it bounces off whatever that wave runs into. And then it returns to a sensor within the boat, and it's going to produce an image on the screen. So whether those objects are fish, which is desirable, or the seabed, we can figure out the depth of the water that we're in, or look for a school of fish. So with ultrasound, we have a transducer which produces a mechanical pressure wave that goes into the body, and it's going to bounce off of some object that's inside. So only about 1% of the ultrasound probe produces this wave. It goes in, and then the other 99% of the transducer footprint is basically a sensor that will sense any returning waves. So it's basically an all-in-one speaker and microphone. It sends and receives cycles millions of times every second. So it happens incredibly fast. These waves are very, very frequent. And these returning images, returning waves get converted into an image on a screen using some very fancy algorithms and physics. So diagnostic ultrasound uses about 20 megahertz. So that's a million hertz, whereas humans can only hear about 16 to 20 kilohertz, so 1,000 hertz. And so it's an order of magnitude larger or more frequent. That's why if you were to put the probe up to your ear, you wouldn't be able to hear anything because it's so high frequency that we can't hear it. All right, so ultrasound images. Basically, sound waves are going to go through the body and then bounce off something or be absorbed. And so there's a couple different fates that can happen to an ultrasound wave as it's going through the body. It can be absorbed by the object and it can heat up. In fact, every time you perform an ultrasound, the body heats up a small amount. You can have reflection, and actually reflection is the desirable. This is how we produce the image. When it bounces off the organ or whatever it may be that we're looking at, the kidney, the liver, the gallbladder, the heart, and we want that image to come back to the sensor and produce an image on our screen. Scattering is undesirable. We don't want that. That is when when the ultrasound hits the object and then kind of goes off in different directions, and it produces a very fuzzy and unintelligible image. Refraction is really not applicable to what we do, so we're not going to spend too much time on it. But basically, the reflected waves allow us to visualize the size, the shape, and the density or consistency of that object. So waves are going to travel faster through solids rather than liquids. And basically, denser objects are going to reflect back more energy, which will produce a brighter appearance on the ultrasound. All right, so speaking of frequency, higher frequencies are good for shallow penetration and high resolution, better resolution, whereas low frequency is going to be able to go deeper down into those deep tissues, such as for OB views or heart or kidney views. But the resolution is going to be worse, as you might expect, because those ultrasound waves have farther to travel into the body. And as a general rule, ultrasound is good for organs such as kidneys, heart, lungs, and not so great for bone or air containing organs. All right, so if all of the physics were confusing, not to fear. There's good news. You can still use an ultrasound. Just like I don't really know how my cell phone works and all the details of the internet and cell zones, but I can still use it. So um, let's get into how to actually use the ultrasound. So there's different modes. The first mode we're going to talk about is called B mode or brightness mode. And basically, this provides a two-dimensional image. And basically, the more dense structures are going to be brighter, and the less dense structures are going to be darker. And so one of the things that we need to get a hold of is the orientation here. So if we look up in the left side of the screen, we see this diagram of a man's body. And you can see that there's a red arrow. That's pointing to the direction of the indicator. On the ultrasound screen, there's a kind of turquoise or green colored indicator that shows the side of the ultrasound probe. So when you think about the orientation, if you were to switch around the ultrasound probe, everything on the right side would now be on the left side. So we have a convention in ultrasound. We want the indicator of the probe to always be to the patient's right or to the patient's head. And so that's how we do it by tradition. And it just allows us to make sense of the image. You'll see when you practice with this, it's very easy to confuse yourself if you don't know which side of the ultrasound image you're looking at. And you can flip the right and the left very easily in your mind. All right, so now moving on to the next mode, M mode. This is basically motion mode. So it takes some time to understand this concept. So up here in the top section, we see this blue outline image, and this is just B mode, what we just talked about. Now we see this red line that's going down through. So what we're going to do in M mode is we're going to graph everything that happens along that red line and only that red line over time. And so if there's any motion that occurs just in that little needle or that one section of space, we're going to graph anything that happens. And in this case, what we're seeing is there's some motion, repetitive waveforms that are forming here. And that's probably either a baby's heartbeat or something that's moving along. Now, why would we do this? Well, because we can take the top of the peaks here and measure, and the ultrasound has a measuring device that will actually calculate something like heart rate. So you measure distance between peak to peak, and it'll actually calculate the heart rate for you. So it's really good at looking for motion. Now, in our case, we're actually going to be using this M mode specifically for pneumothorax diagnosis and looking for any pleural lung sliding or lack of pleural lung sliding, which would be the definition of a pneumothorax on ultrasound. All right, so that's M mode. Doppler mode is basically using this concept of a Doppler. Now, before we get too deep into this, let's just talk about what is the Doppler effect. So you guys all know this inherently because when you are standing, let's say on the corner of a street, and you hear a fire truck or an ambulance approaching, the sound that the siren makes is different as it's coming towards you than when it's going away from you. Now, remember those compression waves from the beginning. If the object that's producing the sound is moving towards you, it's going to compress those waves tighter together so that the frequency will be higher. When it's moving away from you, those sound waves have to travel back towards you, opposite of the direction of travel, and it's going to stretch out those waves just slightly so that you can actually hear the pitch change. So as the object's approaching, higher pitch. As it's going away from you, the sound drops in pitch and it has a lower pitch. Now, what does that mean for the ultrasound? Basically, as an object is moving, such as blood in a blood vessel, we'll be able to see both the color and hear the sound. So Doppler applies to both sound and color, and we're really mostly interested in the color or the visual representation of the Doppler effect. All right, so what does that all mean? It basically means that you can put the probe on a blood vessel and you can see that it's pulsating. And if it's pulsating, it doesn't matter if it's red or it's blue, you know that it's an artery. Whereas if it's kind of steady flow, you can assume that that is a vein. Okay. Another version of Doppler is an amplified version called power Doppler. And this is really helpful if you were going to try to diagnose a testicular torsion or an ovarian torsion where blood flow is only going through the capillaries and we really need to amplify. Spectral Doppler is really not applying for us today, so we won't talk about it too much. All right. So artifact, what is artifact? Basically, it's something that's on the ultrasound, but it doesn't actually exist. And we already know this concept because we do EKGs. When we do an EKG, we know that there's the underlying heartbeat. And then if we shake the patient or the patient scratches themselves, you can see something that might look like ventricular tachycardia or even worse, VFib. Now, of course, we take that into account because it's such a sensitive EKG that it can also pick up on other electrical impulses that are being produced. And we know that that is not an actual representation of the patient's heart. They're not actually in VFib. It's just artifact. So how does that apply to ultrasound? Well, same idea. Sometimes we'll see something that doesn't actually exist in the body, but it's just understanding how the tool works. So one example of this is called shadowing. And basically this is a shadow behind a dense object. So a great representation of that is a gallstone. So what we're looking at here is an ultrasound of the right upper quadrant. And what we're seeing is the gallbladder kind of lying horizontally. And at the bottom of the gallbladder is a stone. And you can see behind it that there is that S label, and that is the shadow produced by the gallstone. Posterior enhancement is another idea that basically tells us that if ultrasounds quickly go through a structure, it can produce a brighter appearance. So what would that look like? Well, here's the urinary bladder in transverse view. And what we see is that the anterior wall of the bladder looks, a certain thickness. And then the posterior wall looks very thick or very bright. And that's just because those waves are quickly hitting here and then coming back quickly, going through that fluid, which conducts ultrasound waves very effectively. So it gives the appearance that it's brighter. It's not actually thicker or more dense in the posterior aspect. It just has that appearance. Edge shadowing is another thing that we can look for. So here again is the gallbladder kind of in a transverse view. And we can see off the edge, we see these arrows are pointing to the shadowing coming off the edge. And it just has to do with the angle of approach of those ultrasound waves. All right, more artifact. We can get propagation artifact or reverberation. The classic case for this is the diaphragm. It's a highly reflective surface. And so those ultrasound waves really kind of get trapped and bounce around and then shoot back to the probe. And it gives us the appearance of a very bright or very dense structure. Comet tails are really good for looking for lung sliding or pleural sliding. And so let's get our orientation here. Here's the chest wall. The probe is above. And what we see here is the pleural line. And then below that would be the actual lung tissue. And so you would have a rib on both sides. You can't see it in this view. It's out of the field of view. But basically what we'll see is these little kind of shimmering, what look like comet tails. And they kind of slide back and forth. Or sometimes people call this like ants marching down the pleural line. And we'll see some actual examples of that later. All right, so let's talk about the actual probe. This doesn't really apply too much for us if we're using the butterfly device because you can go into the settings and just choose what you want to look at, cardiac, abdomen, superficial, and what it will do is automatically switch to the probe that's desirable. But just for the sake of being complete, we'll talk about these different probes. So curvilinear probe is the one in the middle, and this is a lower frequency, kind of goes into the deeper structures. This is good for like OB. You might recognize this if you've ever had a partner with a sonogram. And so this is the one that we would look for with OB or mostly the abdomen. Linear is the next one, and this is the one we would use for like an ultrasound guided IV. And it's going to have much better resolution, but it won't go as deep into the structure. It's more of a superficial view. Phased array is kind of a combination of the two. And what you'll notice is that the footprint of this ultrasound is very narrow, and that's by design. This is good for cardiac, where we'll need to kind of nestle ourselves between two ribs and get a view. Whereas if we have the big curvilinear probe, it would be very difficult to go between the ribs because we would cover multiple ribs with the footprint of the probe. So the phase arrays allows us to get between the ribs and really kind of search around and look for the heart. Another one that's not listed or shown here is called the endocavitary probe. That one's typically used for OB or for rectal, or believe it or not, sometimes we use that same probe to look for peritonsillar abscess inside the mouth. Of course, there's a strict cleaning process for that. All right, so let's talk about some terminology. Um, if we're going to talk about images, we need to be able to use the terms of ultrasound. And so anytime we see a image on the screen, it's because of an echo. So we use this term echogenic or echoic. And so if you have a structure that is very echogenic, we call that hyperechoic. And so it will look bright. If it's less echoic, we call that hypo, so it looks darker than the surrounding structures. If it's the same density, we call that isoechoic. You really can't see the difference. And if there's no echoes whatsoever, that's about as hypoechoic as you can get. So we call it no echoes or anechoic. All right, some more terminology. We'll talk about probe position. Remember, by convention, we always want to put the probe to the patient's right, not their left, but to the patient's right. The indicator should be to the patient's right or to the head. So if we look at the transverse, this is basically cross section. We're familiar with this. If you've ever looked at a CT scan, all the images are typically in cross section, and it basically divides the patient into the top and the bottom half, and then we're going to take a look inside. All right, coronal is not so helpful in ultrasound, but it divides front and back. Sagittal is more helpful, and this is when the indicator of the probe would be going to the patient's head, and it divides their body left and right. And oblique would be any combination of the above. All right. Also, on the device, we'll be able to increase the gain to make it brighter, decrease it to make it darker, and sometimes that's needed. We can increase the depth or decrease the depth to look at structures that are deeper or get rid of some dead space in our image so that we can really zoom in on an object of interest. And of course, we talked about B mode and M mode already. All right, so how at this point, as a paramedic or EMT, can you use ultrasound? Well, we're going to go through the different phases that we're going to roll this out. Basically, phase one contains two items: cardiac motion and ultrasound guided IV access. So after you've completed both this lecture and the hands-on portion, you'll be able to do this in the field, checking for cardiac motion and using ultrasound to gain IV access. Phase two will be in the future, and this will be things like a FAST exam, which you're maybe familiar with. This is known as a focused assessment with sonography for trauma, and we're looking for free fluid, or what we think is blood, in two general areas: the pericardial, that would be a pericardial effusion, or the peritoneal free fluid. And that would be in three different locations: the right upper quadrant, left upper quadrant, and the pelvis. And we'll talk about this at length later. The EFAST is the same as the FAST. It just adds on one more look at the lungs. You actually look in two different locations. And this will look for a pneumothorax, and we'll look for that sliding sign and comet tails. And we'll use M mode if appropriate. And then the last thing that we would learn in phase two would be cardiac. And basically, cardiac, we're just looking at the heart, also known as an echocardiogram, but we're not going to use all the fancy terminology that a formal echocardiogram would require. That is a whole certification that would take months, if not years, to complete. We're going to keep it very simple when it comes to cardiac. Just three things. Number one, contractility. Number two, the size ratio between the right and the left ventricle. And then lastly, is there any pericardial fluid? We can easily remember this by the acronym squeeze, size, and sat. Looking for contractility, the squeeze. Does it look like it is squeezing appropriately, or does it look like it's very weak and barely moving? When you see examples of this, you'll know what I'm talking about. The RV to LV ratio, roughly the RV should be about 1/3 to 2/3 the size of the LV. So in other words, if you had one part RV, your LV should be double that, should be twice as large as the RV in terms of the width. And that is a normal size. If for some reason your RV was about the same size as the LV, that's abnormal. That could indicate high pressures on the right side of the heart. And what would cause that? For example, a pulmonary embolism causing a blockage of the pulmonary arteries. That back pressure goes into the right ventricle, and you get a dilated RV. The RV to LV ratio would be abnormal. Pericardial fluid, we know that can happen from trauma, can also show up in patients that have CHF or end-stage renal disease or cirrhosis. And so there's multiple reasons why we have to put it in the clinical context. All right, so those are the two phases. We're going to talk about phase one today. All right, so cardiac motion. We know that pulse checks are unreliable. If we had a way to look and see if the heart was moving or not, we wouldn't really have to check for a pulse. Now, checking for a pulse is still important because just because the heart is moving doesn't mean that it will produce a pulse. It may not have a strong enough contraction, or you may not have enough blood to pump around. And so we'll talk about that in a minute. But suffice to say that if you're doing a cardiac arrest, you're doing CPR, you're doing your ACLS, and you throw the probe on the chest and you see there's no cardiac motion. This obviously has a very poor prognosis. Only about 0.6% of these patients survive. Um, when you are capturing this, it will go to the cloud on the Butterfly cloud, and we can save these images in order to put them into our PCR later. So we can actually attach this video clip to the patient's chart. And just as a reminder, if you're looking for cardiac motion, it can't be a still image, a freeze frame, because obviously that doesn't show motion or lack of motion in this case. All right, so let's talk about pseudo PEA and true PEA. First of all, what is PEA? Well, it is a organized electrical activity of the heart that does not produce a pulse. It's pulseless. So true PEA means that the heart's electrical activity is firing, producing an organized rhythm, but there's no flow of blood, no pulse. Now, sometimes you can get a little bit of forward flow of blood, but not enough to produce a pulse. We call that pseudo PEA. Now, which one would have a better chance of survival? It's going to be pseudo PEA because you actually have some forward flow of blood, whereas in true PEA, you have no forward flow of blood. And basically, the only way to tell if there's any motion of the heart is to take a look at the actual heart. And so we can do that with ultrasound. All right, and just a reminder, we've designed phase one so that cardiac motion is going to be checked during cardiac arrest. You can use it as part of your termination of resuscitation checklist. And remember, it's one piece of the puzzle. You're still going to do all the things that you normally do. And remember, when you're using ultrasound during cardiac arrest, the same rules apply. We want to limit interruptions in chest compressions, definitely less than 10 seconds. And there's some tricks that we can show you during the hands-on portion of getting the probe ready, getting the setting correct, getting the Lucas in a position where you could check, or the manual compressor. But basically, you want to be ready as soon as the compression stops. You can start looking, because as you're learning, it's going to take some time to know exactly where to point the probe and some good technique. So you don't want to be doing that during the compression pause. You want to be ready to go in advance. All right, and here is a reminder, this is the updated 2024 TOR checklist. And so at the bottom, you can see there, confirm no heart motion with ultrasound if capable. And so when you're done with this training, you'll be able to do that. And again, you're still going to go through your step 1, 2, and 3. But basically at the end, if you've gotten through all steps and you want to check to make sure there's no heart motion, that will definitely influence your decision to stop this resuscitation, or to continue going. All right. The other part of phase one is the ultrasound guided IVs. And basically, the Butterfly app has some great videos. I'll make some recommendations at the end of this presentation of which ones to watch. But basically, you can find a deeper vein and access it with ultrasound and literally watch the needle go through, thread the cannula, and get an IV with ultrasound. I will provide some uh, mannequins or gels that will allow us to practice on the gel to start. And then if you're not going to insert the needle, you can also practice locating the vein and telling the difference between a vein and an artery on your partner or even on yourself. All right. So that's phase one and phase two. Now we're going to move on to looking at normal ultrasound images. And the idea here is that if you see enough normal images, you're going to be able to see when something is abnormal. I encourage you guys to watch the videos that are in the education tab of the Butterfly app. And I also encourage you to practice on each other or even on patients by looking at their cardiac view, looking at their right upper quadrant, just to get practice. As long as it's appropriate, the patient's not an extremis, they are agreeable. There's no reason not to practice this, especially if you've got a little bit of downtime. All right, this looks a little bit overwhelming at first. So let's kind of just focus on the leftmost column, the subcostal view. As you can see, there's three different diagrams here. We start at the top. There's a very kind of cartoonish diagram number one, and we see that that indicator is pointed to the patient's right. So this is going subcostal, meaning we're kind of going underneath the ribs or underneath the xiphoid, and we're going to angle upwards towards the heart and try to get this view in the second area here, where it shows the diagram of the right and left chambers. The first thing that you'll see is the right ventricle, and then this is the orientation. So it's almost as though everything is kind of flipped upside down, because remember, you're looking from the bottom up. The bottommost section here under subcostal is an actual ultrasound, and you can see what's represented above. This is the view that we're going to be using most, and so get to know this view, the subcostal or subxiphoid view. IVC is another way that you can go check, and you can see by convention, again, the indicator is pointing to the patient's head. And basically what we'll see is the IVC. Why look at the IVC? Well, it's helpful to determine volume status. And again, this is not something that we're going to be doing in the field, but I would like you guys to know how amazing this tool is called ultrasound. So IVC, if the patient was in volume overload from CHF, right? Sometimes patients have both CHF and COPD. Wouldn't it be great to be able to tell what their volume status was? Are they volume overload, or are they even hypovolemic? Well, by looking at the IVC, you can actually get a pretty good idea. So as the patient breathes, the IVC down here should increase and decrease in size. We call it respiratory variation. If a patient had volume overload, that would stay big and taut. It wouldn't move much at all. And that would be volume overload. Now, if a patient had sepsis, what we would see is that this volume in the IVC is very collapsed. And those two edges could even come and touch together because there's so little volume in the IVC. So it's really helpful for determining volume status. All right, the next one will be implemented in phase two of our ultrasound rollout. And this is basically moving on to a fast exam. So right upper quadrant, this is what we would see. Remember the indicators to the patient's head. And what we're going to look for is the liver and the kidney on the right side. So we're going to look for this space in between, and that is called Morrison's pouch or the hepatorenal recess. Normally, there should not be anything there. You should not see any black, dark fluid there or free fluid. It should just be a potential space. Same thing on the other side, the left upper quadrant. And what we see here is that this is the splenorenal recess, and we shouldn't see any fluid in between the kidney and the spleen on the left side, or for that matter, between the spleen and the diaphragm up on the top or superior aspect of the spleen. And you can see the actual images below. Now moving on to the pelvis, there's actually going to be two views of the pelvis. We're going to start with the sagittal view, where the indicator is going to be to the patient's head, and we're going to go down right above the pubic symphysis or the pubic bone. And what we'll see is kind of a triangular shaped bladder. And this is both diagrams show a male and then a female, as indicated by the uterus. And then the ultrasound below is actually a male because we see the prostate. And what we'll see is that if there is free fluid in the pelvis, we would see it accumulating above the bladder or on the superior aspect of the bladder, as indicated by those multiple gray arrows. The second view of the bladder is going to be the transverse, and this is where the bladder almost takes on a square appearance. And you can see that the prostate is posterior to the bladder. And in this case, the indicator of the ultrasound probe is going to be to the patient's right again. And that's what it would look like in transverse. Now, moving on to what now would be an EFAST, because we're adding on the pneumothorax, we're going to look for two locations in the chest, both the right and the left. And what we're going to look for is two ribs, and then look for the pleural line in between. And what we'll see is that here in the actual ultrasound image, we see this rib, and we know that because there's shadowing below. And then we see this bright white pleural line on each side of that rib. Now, as that person is breathing, they will produce that sliding of the pleural line and produce those comet tails and ants marching. Here's another example of the liver and the kidney. This is actually rib shadowing that we see here. And then another example of the liver and kidney. Here's a normal right upper quadrant. This is a beautiful image. And what we can see is some structures here. So we see that there is Morrison's pouch. That's the space between the liver and the right kidney. Also above the liver, of course, is the diaphragm. And above that would be, of course, the lung. Now, what would it look like if there was fluid in Morrison's pouch? It would look like this. We see there's free fluid. You see this kind of wedge-shaped black fluid that's coming in, and it's separating that potential space. That is a positive fast. In the setting of trauma, that is blood, and in the peritoneum until proven otherwise. That is a bad sign. This patient is going to go to the OR probably pretty quickly. So, for example, if you had a patient who was in an MVC, blunt trauma, had belly pain, maybe they're hypotensive, maybe they're tachycardic, you eventually, in the future, could throw the ultrasound probe on the belly and say, oh, there's a positive fast, there's free fluid in the right upper quadrant. And you could literally call that into the receiving hospital or trauma center and say, hey, we have a positive fast, free fluid in right upper quadrant, Morrison's pouch. And you can notify the surgeon and they can start to prep the OR so that patient can go to the OR without delay. Let's look at the left upper quadrant. Now we're going to look at the spleen and the kidney, the splenorenal recess. And what we'll find is that if we put free fluid in here, the kidney is down here. And what we see is that that free fluid actually accumulates on the superior side of the spleen. And that's that black free fluid labeled as so. All right, moving on. Now we're going to look at what it would look like if we had a pneumothorax. And so we're going to be looking between two ribs, and we're going to be looking for that pleural sliding. And if there's no pleural sliding, no comet tails, no ants marching, that could indicate a pneumothorax. Here is an example of what I've been talking about. These are comet tails. You can see the pleural line, and you can see those comet tails are kind of shifting side to side as the patient breathes. If the patient holds their breath, you won't see any movement, and it may look like a pneumothorax. All right. So what would it look like if a patient did have a pneumothorax? Well, we can see here that we see some motion. It looks like the patient is trying to breathe, but we don't see any motion beyond that pleural line. There's the pleural line. And what we see is that beyond that, I don't see any sliding. I don't see any comet tails. This is a pneumothorax, especially in the right clinical setting. All right. So remember at the beginning, we talked about M mode and how everything that moves along that line will be graphed out over time. And so if we have the plural line here, that's indicated by that white arrow, and this yellow arrow is basically our what's going to be graphed down in the lower segment. That's going to be graphed over time. And what we see is that um, this is a good sign. This is what it should look like. And so nothing is moving above. That gives these big long line appearance. And then as the patient breathes, it will produce this distorted image below because everything, the lungs are moving past that line that is the yellow line, the M mode line. And basically, what we see is that it gives the appearance of what's called the seashore sign. So the seashore is the beach below, and then you see the horizon beyond. Now, if we don't see any motion along anywhere, so this is the plural line that we see again, and no motion is occurring along this, we'll see that graphed out over time, and we don't see any motion. That's a bad sign. That indicates that this is a pneumothorax, and that's a way you can confirm pneumothorax. So the ways to confirm pneumothorax, once again, no comet tails, no lung sliding, no ants marching, and the barcode sign would be positive. All right, here you can see them side by side. So you want to be at the beach, you want the seashore sign, and the barcode is bad. All right, we're going to go through an EFAS, and I'm going to walk you guys through this from the beginning. So we're going to start over here in the right upper quadrant. What we see is there's no fluid in Morrison's pouch between the right kidney and the liver. Here we are, left upper quadrant, no fluid in the splenorenal recess. Now we're onto the bladder, no fluid above the bladder. Now this is the heart, there's no fluid, subcostal view. And finally, I see comet tails and lung sliding down here. All right, so that's a negative E fast. I know that was fast, so we'll go through it one more time. No fluid in right upper quadrant, Morrison's pouch. No fluid in the left upper quadrant, splenorenal recess. Moving on to the bladder, there's no fluid above the bladder or superior. This is subcostal view of the heart, no fluid around the heart. And finally, no evidence of pneumothorax because there's lung sliding. All right. And when we get into cardiac, these are the four views that we would look at of the heart. And remember the subxiphoid or the subcostal, that's the view that we're going to be focusing on when we're looking for termination of resuscitation or looking for a lack of cardiac motion. So we're already familiar with that. We're going to add on three additional eventually, but just giving you guys a little taste of what's to come. So when we look, we can do two different parasternals. And so the indicator is going to be to the patient's right shoulder when we look at this parasternal, and it will give us this appearance where we can see the left ventricle and we can see both the mitral valve and the aortic valve in one view. That's called the parasternal long axis. If we turn that 90 degrees on its axis, we can now put the indicator towards the patient's left shoulder, and that will produce this kind of cut in half donut kind of appearance. And we'll be able to see mostly the left ventricle, but also some of the right ventricle, depending on how we angle the probe. And this is helpful to determine if there is a good contractility, also ventricle size, and a host of other things. All right, and then the last is called the apical four-chamber view, and you're going to point the probe towards the heart in this direction, and you would see this great looking appearance here. All right, so almost done here. Remember, for hands-on, we're going to encourage you guys to watch these videos. Basically, there's a education tab. If you're looking on the phone app, it has a what looks like a graduation hat. If you click on that, there's hundreds of videos there. The one I would like you guys to watch is called the subcostal four-chamber view. before you try to practice on a partner. It's a great video. It walks you through very quickly just the basics. And then second, I would like you to watch the ultrasound guided peripheral IV insertion video um, as a primer before you do the practice. Remember, practice first on the IV simulator gels that are very easy to get used to. You can actually put the needle in that, and then you can also test for just compression, looking the difference between a vein and an artery on your partner. Remember, arteries are pulsatile and veins will compress. All right. Well, I want to thank you for your attention. If you ever have any questions, feel free to reach out to me, send me an email, or just contact your immediate supervisor and they can get in contact with me. I wish you all the best in your learning. Please remember to practice and reach out if you have any questions.